I'm an interventional cardiologist, so I can open any artery that has a blockage that I can get to. Now that means arteries to the brain, arteries to the arms, arteries to the legs, arteries to the intestines, arteries to the kidneys, arteries to the legs. So that's the kind of practice that I have, okay? This month, September, is Peripheral Artery Disease Month. So peripheral as in away from the heart. So tonight we are not going to be talking about the heart at all, except when we talk about risk factors, okay? We are going to spend a lot of time talking about risk factors, and the truth of the matter is it's not going to matter where in your body the blockage is, the risk factors are the same. So we will spend a bit of time talking about that, okay? So what I'm going to show you first, this picture is of an artery, okay? This is the abdominal aorta. So think about your belly button. The arteries to your legs start at about belly button level. So big artery comes out of the heart, arteries go to the arms, artery comes down the backbone, half going into each leg. And that division point is about belly button level. Okay? Now, in this particular picture, this dark stuff is dye. We're injecting dye. This is a catheter. And you're actually seeing dye being injected into the catheter that's going down the right leg, right? It stops right there in the left leg. So this patient was having severe pain in the left leg because the left leg was getting very little blood flow. Now, if you really look closely, you'll see that this patient has already had blockages. What I'm showing you right now are stents. Okay? There's stents there already. So despite having his artery opened before, it's closed again. Okay? It's closed again. So many times we're faced with opening an artery the very first time. Many times we're faced with opening an artery a second or a third time because that artery continues to close. Now remember, we can treat the blockage, but we don't ever cure the disease. And the disease is that atherosclerotic process that puts the blockage there in the first place. Even patients who have bypasses, now if a surgeon puts a bypass graft in, he doesn't put a diseased bypass graft in, right? He puts a pure, pristine bypass graft. So at the time that the bypass graft is placed, it's completely normal, completely free of any blockage. But many patients will develop blockages in the bypass grafts. And that's either bypass grafts for the heart or bypass grafts for the legs. So the bypass, or my procedure of, balloon, stent, whatever I use, that doesn't cure the disease. We treat it. So it is going to be very important, especially once any blockage develops in any of your arteries, to very strongly treat the risk factors in order to try to decrease the possibility that the blockage returns, and maybe to lessen the possibility that those blockages become severe. So in this patient, we're faced again with opening an artery. It's been closed before, we've opened it, it's closed again. Okay, now I have actually passed a guide wire through that total blockage. And so you see some flow now going through that artery. You look at all the stents there. The knee is here. You see the stents? The hip is here. Stents, stents, stents. Okay? We were able to demonstrate that the arteries below the knee are actually open. I'm going to take the plaque out of this entire segment now. I'm actually going to use a device to cut the plaque out of that entire stented segment. Okay? I'm going to show you some animation of some of the devices that we used. The particular device that I use here, and I'll show the animation of that, is called a turbo hawk device. It actually cuts the plaque out. We actually bring the plaque out of the body with this device. What you're looking at right now, what do you think that is? This thing right here, and you don't know. It's a net. It's a net. It's a distal protection device because if I'm working in these arteries, depending on what I'm using, there can be some debris liberated by the process of opening the artery. Some of our tools have a more propensity to produce debris than others. We know that. So sometimes we actually put a device in to catch the debris. So this is a net. It's a distal protection device. And I've placed that net in a part of the artery that's wide open so that it collects anything liberated from the device that I'm going to use. That's the device. And you can see the window here. You see the little opening there? That window? When we activate this, a cutting device comes out of that window and actually shaves off the plaque and puts the plaque down here in the nose cone. So when I bring this device out, the plaque comes with it. We can actually look at the plaque, feel the plaque. Many times it's soft material. Sometimes it's fairly calcified. Now, at this particular hospital, I was actually the first person to use this device in the Valley back in 2004. We've participated in studies with this device. I mean, initially, we would take the plaque out, throw it away. Then I started saving it, and my nurse at the time would make paperweights as show and tell things. Okay? And then several companies got the bright idea, well, you know, we might be able to learn something from the plaque. So we actually took part in 2 studies here. The first was just to take the plaque out and send it to a company to have them analyze the plaque. The second study was to identify patients with severe plaque in both legs so that we would take the plaque out of one leg, treat them with a particular drug, bring them back about 6 weeks later, and take the plaque out of the other leg and send it to see if the drugs that we used had any impact on the plaque. Okay? The information from those studies is only, the information that we've been given is only that the plaque in diabetics is different than the plaque in the non-diabetic. So subsequent to that, many studies have to be able to show what happens with the diabetic patient just as they do for the non-diabetic patient. Okay? What we haven't been given, though, and we used actually 3 different drugs, we haven't been given the information of whether or not either of those drugs helped or not. And we all have our theories about why we don't have that information, but we don't have it right now. All right, so that's the device. Once we took the plaque out, that's a balloon. This is dye now going down the leg. The net's right there. So previously, none of this artery was open. Remember? Okay. I took the net out just so that we could make sure that there was normal blood going down to the foot. So now this patient goes from having very little blood flow to the foot to having normal blood flow to the foot. Okay. So first, the device that you just saw. This is the device. This yellow is the plaque. That's the window opening. You see the cutter? And shaving the plaque off, and the plaque goes right down here into the nose cone. This device is directional, so I know exactly where this window is pointing, and depending on how much we turn the device, we cut a different aspect of the plaque. Okay?
How big is that device?
Depends. We have different devices because the arteries are different. Down in that patient's leg where I had the net is a smaller artery than back up where those stents were at the hip. So we might have chosen different devices to do that patient's, or remove the plaque in that patient if we needed to. I will go back to that one if I need, because there still may be some questions.
Can you use one of those devices for the heart?
Okay, not that one. Okay, just let me see if I just go back to this one for a moment. Just stay there for a second. Okay. This particular one, no. Okay, this is the one. This is specifically made for big arteries in the legs. I don't use this device in the kidney arteries. I don't use it in the intestinal arteries. We don't use it in the heart, and we don't use it in the brain. Okay? So we can direct this device different aspects of the plaque to take out as much plaque as we can, many times smoothing it with balloon, and many times that's all. Whether or not the blockage is the first time, or whether or not, as in the patient that you saw, there's blockage within a stent. Now, we've got to be careful with the stented patients because we don't want to cut the stent, right? And so we have to be careful with that. All right, now this is a totally different device, okay? This is a device that is called a Diamondback device. It actually sands the plaque, okay? Now, that first device that I showed you that cuts the plaque out works perfectly well in soft material. There are forms of that device that work very good in calcium. This device, its forte is calcium. So very hard plaque. It sands the plaque off, and just as the other one, we have different sizes. Initially, we thought, because the company told us, oh, there's not going to be any debris that you liberate with this. The particles are too small. They just float through the vasculature and nothing happens. Well, we certainly found out that there can be debris. So there are certain distal protection devices that we even use with this one. Okay? There is a form of this device that we can use in the heart. Not the brain, not the arteries going to the kidneys, not the arteries going to the intestines. Okay? But there is a form of this that we can use in the heart now. So this is the one that actually sands the plaque off. And many times after using this device, we'll still put a balloon in just to smooth things out, hoping not to put in stents. Now, if you think in terms of what we do with the heart, the best that a cardiologist can do for any heart patient is to put a stent in. Okay? We try to avoid putting stents in patients in the legs unless we absolutely have to. So usually it's the second time around.
Why is that, Doctor?
Well, in the heart, all of the data that we have says that the stent's the best. In the legs, we're comparing different devices with balloon. There's been very little device against device. So to be able to say the stent's the best, maybe yes, maybe not. In those arteries right after the in the portion of the arteries right after the artery divides, those are huge. Those are big arteries. So most often we do put stents there. Down further in the leg, arteries get smaller. We try not to put the stents there. One of the other devices that we have is actually a laser. We use the laser in the heart. We use the laser in the legs. And there are other applications. This is actually a plaque that is very hard to get the guide wire through, but we can actually bring the laser right down on the plaque, and the laser energy softens and vaporizes some of the plaque. It's not so much pushing with the device. There's a laser bubble that's generated right at the tip of the catheter. We have to just allow the catheter to work a bit. Now, fortunately at Valley Baptist, we have many tools to use. Okay? So my toolbox or my toys, I have more toys here, more tools here than I do at other hospitals. Okay? So what we can do here then is to match the blockage with the technology, because not everything works for every blockage and not every patient. Certainly there are times that we only use balloon, and there are times that we put stents in. So as I've said before now, blockages can occur in the heart. Those arteries go into the arms. Those arteries go into the brain. The kidney arteries are here. The intestinal arteries are here. And the leg arteries. And you just saw how we opened one of those. So now the issue gets to be, remember I said earlier, we don't cure the disease. We treat the disease. So question one, what makes one person develop blockage and another one doesn't? Question two, you've had a blockage, we've treated the blockage, but the blockage comes back. Why does that happen in one person and doesn't happen in the other? Okay? And all of it comes down to the risk factors, some of which we can manage, some of which we can't. So if the patient has a very strong family history, so mother or father, the aunts and uncles, brothers and sisters, if everyone has atherosclerotic blockage, then the genetic factor may be a very strong factor in that patient, and unfortunately I can't change the genes. Right this minute we can't do the gene transfer to basically take away that atherosclerotic gene. We can't do that just yet. Okay? In many circumstances, in general, men have more blockage than women. Can't change whether or not you're a man or a woman. So now it gets to be, what is it? Can't change that. Well, I can't change the chromosomes. Let's put it that way. How's that? How's that? Okay. I can't change the chromosomes. I guess there was a time when I didn't have to qualify that, but now I guess I do. Can't change the chromosomes. Okay. So it really gets to be, what risk factors can we change, and do they have an impact? And now, what's listed on this slide are common risk factors. Diabetes is there in red for a reason. If we were going to number these, I'd have to have diabetes first, second, third, fourth, and fifth, and then I'd add something else. So diabetes is the strongest risk factor in developing the blockages. Okay? Now, there's not a cure for diabetes, but it certainly can be treated. And it can be treated with a particular goal in mind, and I think I have a slide here a little bit later. It's not enough just to take your diabetic medicine. Okay? There has to be a goal, and that goal is associated with improved outcomes. There is a test called a hemoglobin A1C. Are there diabetics in the room? Okay. Do all of you know what your hemoglobin A1C is? Okay. This is a 3-month look backwards, 3 months backwards, to see how well your diabetes is controlled over the past 3 months. So you can't fast over the weekend, go in Monday morning, have a blood test, and have this test be normal. You can do that with a fasting blood sugar, okay? But the hemoglobin A1C, you can't. That's why it's that much more important. So a hemoglobin A1C of less than 7. A hemoglobin A1C less than 7. Now, if you're diabetic and your hemoglobin A1C is greater than 7, something is very wrong, and 1 of 2 people is not doing their job. Okay? So now the question gets to be, who's responsible for treating your diabetes? You and your doctor. Those are the 2. So if the hemoglobin A1C is less than 7, 1 of those isn't doing their job. Either the doc isn't using the right medicines, right doses, following that kind of thing, or the patient isn't taking the medicines, getting enough exercise, adhering to the diet. Okay? 1 of those 2 has to get their act together if the hemoglobin A1C is greater than 7. Okay. The next thing on the list is placed second because it's second most important, and that's smoking. You know, there's still people who are not sure whether or not smoking is an adverse risk to their health. And it's primarily people who really don't want to stop, so they're going to say, oh, it's not hurting me, until it can get to be too late. I mean, too late to change the abnormalities that can occur lung-wise, the blockages that can occur heart-wise, brain-wise, leg-wise, wherever there are arteries that are blocked. And so, treating the diabetes and stopping smoking are 2 of the most important risk factors to change. Notice I haven't said it's easy. By this time, I mean, a person who's smoked for a long time, it is very difficult to stop. It's very difficult to stop. And it's very difficult to stop because it gets to be a brain thing now. Okay? It gets to be a brain thing. The nicotine is not the thing that hurts the lung, and it's not the thing that puts the blockages there. It's the tar and the other things that are in the cigarette smoke. But after a person has smoked for a long time, the brain wants something in the fingers. The brain wants a particular taste, a particular smell. The brain wants something to happen at 10 o'clock when they have the coffee with the friends. It's a brain thing. Because it's difficult to stop, and the reasons for not being able to stop change from patient to patient, there are gums, there are patches, there are pills, okay, to help. Now, I'm just going to tell you, and this is not an advertisement, my patients who have done the best with stopping smoking are those who are at least trying the electronic cigarette. Okay? And what I find is that, and this has nothing to do with brand, what I find is that immediately the cigarette consumption goes to half. So if they're smoking 2 packs a day, when they start using the electronic cigarette, they go down to 1. And it's harder to go further and further, but that electronic cigarette satisfies some of the things that the brain wants. So there's something in the fingers. One of my patients puts it in his pocket, so now his brain says something in his pocket and the pack of cigarettes isn't there. The electronic cigarettes are there. So the taste, the smell, what looks like smoke, different levels of nicotine. Remember, nicotine is not the thing that puts the blockages there. I have one patient who basically needed to try multiple of them in order to find one taste that he liked. But the important thing is that the consumption of the cigarette goes down. Electronic cigarettes aren't perfect for everyone, just like the pills and patches and gums and pills aren't. Okay? But the idea of decreasing the cigarette smoking is so important that if you are a smoker, I'm just going to encourage you to do whatever you can do. If it means, you know, putting a hand, holding an ear and jumping up on one leg. I mean, if that's the thing that decreases your cigarette smoke, I would want you to do that. Okay? Elevated cholesterol. So especially if you're diabetic, and you know, the word elevated is here, and I should probably put that in quotes, because I'm going to ask you a question. Suppose you're diabetic, or not, and you have a blockage, which I've just opened, but your cholesterol is normal. What about that? I mean, do you think you don't have a cholesterol problem? Your cholesterol that we measure is normal. Okay? And that's a pitfall at times because it gives a bit of false sense of security. Your body needs cholesterol. There are some chemical reactions in your body that if I made your cholesterol go to 0 at some point, you'd die. Your body makes cholesterol. Some of the cholesterol comes from the diet. So changing your diet in some people can drastically reduce the cholesterol. In some people, it doesn't budge because the body makes a lot of it. The important thing, though, is cholesterol is a major part of the plaque. So if you're a patient that has a blockage and your cholesterol is normal, your body isn't doing something proper with that normal amount of cholesterol that it has. Okay? So many times, once I find a patient with a blockage, I start a cholesterol drug before I've gotten the results of the blood test, because it's not going to matter if I'm going to treat them with a cholesterol drug or not. And here's the reason why. Some of the cholesterol drugs do more than lower your cholesterol. Some of the cholesterol drugs have been proven to stabilize the plaque. Okay? So at this point, what I'm after plaque stabilization. If I also get reduction in cholesterol, that's great, but I'm after plaque stabilization. So that person with the blockage, I'm still going to put on a cholesterol-lowering drug. There are only several that have been proven to stabilize the plaque, and we're talking about some of the statins. Okay? And on that list, the old drug pravastatin or Pravachol, simvastatin or Zocor, Lipitor or atorvastatin. Okay? Those three. Crestor's trying, and at some point we may get enough information to say, yes, Crestor stabilizes the plaque. So my patients that have blockages, regardless of what their cholesterol is, they're on one of those 3 drugs that have been proven to stabilize the plaque. And once in a while, I'll have to call a primary care doc to say, you can't take this patient off the cholesterol drug just because their cholesterol is normal, because they have blockage. And we're trying to decrease the possibility that the blockage comes back. And that's one of the things that we're able to do. Okay? It is important to treat the high blood pressure. There are goals, and we'll talk about that a bit. So it's certainly important to take the antihypertensive regimens. We have guidelines on how we're supposed to treat high blood pressure. There are multiple different drugs. We're given guidelines in terms of which ones we should add first and which ones we should add second and third. Okay? It's very important to treat the hypertension because of multiple things now. Decrease the possibility of stroke, decrease the possibility of heart attack, decrease the possibility of heart failure, decrease the possibility of kidney failure. So treating your blood pressure is extremely important in reducing overall health risk. It's certainly important to get as much exercise as possible, but I want you to take a look at this list and see what are the most important things. So I don't want the person who smokes to put so much emphasis on losing weight but not stopping smoking. Okay? I mean, weight's on the list, but it's not over on this side. Physical activity is on the list, but it's not over on this side. Okay? So activity is important, losing weight's important, but we can't lose sight of the major goal, and that's to have the diabetes treated, to stop smoking, have the cholesterol treated. Have the cholesterol treated, have the hypertension treated. Okay? Okay. We're going to talk a little bit about the heart. Now, I'm going to tell you what this slide is about in just a minute. Is there anybody in the audience who is not a diabetic now? Not a diabetic, but you've had a heart attack already? Anybody that's not a diabetic and you've had a heart attack? Okay, now, stand up for a moment. Okay. Non-diabetic, heart attack already. So now, diabetic who's never had a heart attack. So diabetic in the room who's never had a heart attack. Stand up. Okay? All right. So diabetic who's never had a heart attack. Okay, now listen. The diabetics who've never had a heart attack are at the same risk of having a heart attack as the non-diabetic who's had a heart attack already. The diabetic who's never had a heart attack is at the same risk of having a heart attack as a non-diabetic who's had a heart attack already. That brings us back to how important it is to treat the diabetes. When you treat the diabetes, these are all the things that get better. Heart attack goes down. Any diabetic-related death goes down. Improvement in the eyes, that's retinopathy. Kidney failure decreases. Stroke rate decreases. Heart failure decreases just by treating your diabetes. I'm going to go past that one. This is that hemoglobin A1C. So the issue is, what's the definition of treating your diabetes? A hemoglobin A1C consistently less than 7. Okay? So what I showed you initially was that peripheral artery disease patient that we opened the artery. So for the diabetic person, 3 times the risk of developing blockages in the legs compared to the non-diabetic. And the distribution of those blockages is a bit different. Most diabetics are going to have blockages below the knee, smaller arteries, in addition to above the knee. The person that smokes high cholesterol, they may have only blockages above the knee in the bigger arteries. And you've seen patients around, or people around the valley who've had amputations, right? Most of those patients are diabetic, And they've developed blockages in those smaller arteries. Started out maybe with a sore place on a toe or an ulcer, which worsened and worsened and worsened that we couldn't save the foot or leg. Okay. So we're going to stay with this peripheral artery disease for a bit. What symptoms might you have, and we'll stay with the legs for a moment. What symptoms might you have that may suggest that you might have blockages? First of all, we've talked about the risk factors. So if you're diabetic, smoking, high blood pressure, hypercholesterolemia, you have the risk factors for blockages anyway, and it's a reasonable to be screened. Screening means your primary care doc asking you questions about your history, about your physical activity, feeling your pulses. I mean the doctor actually putting hands on you to feel pulses behind your knee and your feet to see if you actually have the pulses. I mean, we can actually, believe it or not, doctors can actually tell things by putting their hands on you and listening to you. Okay, we can tell things. Discomfort in your legs, not just saying pain, not saying cramps, discomfort in your legs, which would basically be, I'm just going to stand here, the big muscles, thighs or calves. So those muscles, if they are not getting enough blood flow when you're walking, there's going to be discomfort in those muscles. So discomfort in your legs, and we'll just leave it at that because we want to get you screened since there are multiple reasons that there might be discomfort in your legs. Discomfort in your legs when you walk that goes away when you stop walking is suspicious for blockages until proven otherwise. Now it could be arthritis in a hip or a knee. Okay? Anybody die from arthritis in a hip or a knee? I mean, uncomfortable, limited, yes, but arthritis in a hip or a knee, that doesn't take your life. But if there's a blockage there in the legs, you have a higher chance of blockages someplace else. The someplace else, the heart, the someplace else, the brain. So we want to find out whether or not you have blockages in the legs so that we might be able to decrease your chance, your possibility of developing blockages someplace else. So now how about if patient comes in, discomfort in the legs when they walk, we don't feel pulses, we do some various tests, we find blockages, but that person, nothing going on in the arteries going to the brain right now, nothing going in the heart right now, but we found blockages in the legs. What do you think we can do? So we treat the blockages in the legs and we treat the risk factors. Same risk factors that would produce blockages in the heart and the brain. So even if we find blockages in the legs before a patient has blockages in the heart or the brain, we can actually decrease their chances of having blockages in those two places. Okay? So it's up to your physician, and initially your primary care doc, to try to sort out why you might be having discomfort in the legs. Again, it might be arthritis. It might be a pulled muscle, okay? But it also might be blockage. And there are very simple ways that we can do that we can find out that answer. I'm going to go to this. Actually, we'll do that. Now, one of the things, let's go back to here. Simple. A very simple screening test for blockages in the legs is something called an Ankle-Brachial Index. If there are no blockages, the blood pressure in your arms ought to be the same in your legs. If there are no blockages. If there are significant blockages, the blood pressure in your legs is going to be lower. So when we measure the blood pressure in the legs and we put the leg blood pressure on top and divide it by the arm blood pressure, if they're both the same, this answer is 1, right? So the closer this answer is to 1, the less the possibility that the person has blockages. As this number gets further and further below 1, the higher the possibility that there's severe blockage in the legs because the blood pressure in the legs is significantly lower. This is a basic screening exam, okay? By the time the patient gets to me, though, we need to do something else. Because now I'm more interested in where the blockage may be in the legs. Because now it's time to strategize what we may need to do, where the blockage is, what I may need to do to open the artery. So then we use Dopplers, sonograms. Okay? So if you've had a sonogram for any reason, we can use that same technology to track blood flow in the legs. But we use that same technology to track blood flow in those arteries going to the brain, those arteries going to the arms, those arteries going to the intestines, those arteries going to the kidneys. That same Doppler technology allows us to find evidence of blockages, something very simple. We may need to do more complicated things before the angiogram, like a CT scan or an MRA, but most often the patient's history, what they tell us, the physical exam, touching them, and the Doppler tells us the answer. And with that information, we can take that patient to the catheterization laboratory, put the catheters in, find the blockages pretty much exactly where we thought they were, and then devise a plan to open those arteries. Okay? Now, just before we get to some of the treatment, we've been talking about blockages in the legs, and I've said to you that there could also be blockages in those arteries going to your arms. Not often, but sometimes a patient will develop discomfort in the arm when they use the arm. Notice, not just at rest. Now, certainly that could be a shoulder issue, but it could also be decreased blood flow. When a patient comes into my office, blood pressures are taken in both arms because we're actually looking to see if the blood pressure is the same in both arms. And if there's a significant decrease in a blood pressure in one of the arms, most often it's the left one, there's only one reason for that. And the reason would be a severe blockage there. Just because a blockage is present doesn't mean that we have to open it. Okay? That's not treating the risk factors now. That's me going in to open the artery. So I have a patient who has a total blockage of the artery in the arm, and she has absolutely no symptoms. So now if I open the artery in her arm, have I made her better? I haven't. She's not having any symptoms whatsoever. What I've done, though, I've subjected her to some risk, and I've not made her any better. So that we don't do. I also have a patient who has a total blockage in one of the arteries going to the legs, doing all the walking they want because their body has opened tremendous collaterals around that blockage. Have I opened that artery in her leg, in his leg? Absolutely not. We're treating the risk factors. Opening the blockages has to do with the symptoms. Remember, we're talking about symptoms. We're talking about discomfort of some type related to the blockage. So if there are symptoms related to the blockage, then it's appropriate to open the blockage. Everything that we do, putting things in, opening blockages, there's small risk to it. And we as docs have to decide, along with you, the patient, whether or not it's appropriate to subject you to the risk or not. And so if I'm going to say, listen, I'm not going to help you, I certainly shouldn't be subjecting you to the risk. If it's very clear that the discomfort that you're having in the leg is because of the blockage, and I'm fairly confident that I can open the blockage, then I can say your risk is small, but the gain from my opening the blockage is higher than the risk, and therefore it's appropriate to proceed. We're still going to treat the risk factors regardless of whether or not I open the artery. Okay? But again, it's going to be important to make sure that we're opening the artery for the right reason. And the right reason is not just because it's there. Okay? If I could say to the patient, well, if we don't open the blockage, something's going to get worse. Either you're going to develop sore places on the feet that may not heal. Once in a while, a patient, for example, needs to have foot surgery, but they have severe blockages. And we know full well that if the podiatrist starts to cut in the foot without me giving that foot more blood flow, the cutting that's done isn't going to heal, and we're going to have a big mess in the foot. So certainly we'll open the artery in those circumstances to make the risk of having the foot surgery much less. Okay. Contrary to the heart. Now, you're never going to have a doctor tell you, if you have blockages heart-wise and you're having angina, when you start to have angina, keep walking. You're not going to have a doctor tell you that. Okay? Because we don't want you to become symptomatic and deprive your heart of blood, which could put you at risk for having a heart attack. That's a little bit different in the legs. Someone who has pain in the legs because of blockages, if they continue to walk, trying to walk through the pain a bit, the body actually makes some collaterals, little blood vessels around the blockage. Now, those collaterals may be enough to decrease the symptoms, maybe not. But we certainly will encourage the patient to still walk a bit. Okay? So, on this list of therapeutic options, and this is for blockages in the legs, we talked about the risk factor modification. Here's exercise therapy. There is one drug, we'll get to it on the next slide, that I'll talk about. And then the various things that I can use to open the arteries. So there's angioplasty, there's stenting, there's all the things that allow me to bring the plaque out of the body or modify the plaque. And just as the heart, there can be bypasses done in the legs. Okay? Most often those bypasses are done with vein from the legs, just like the heart, but there can also be synthetic material that's used. Many times after, I'll just tell you something. This patient that I showed you, that patient also had a previous bypass graft, which was also totally blocked. So we actually went back to open his own arteries. So yes, bypass grafts can be placed in the legs, just as they can in the heart. There's one particular medicine. This one is pentophilin. That's not the one that we use very much. This one, Pletol, has been approved to relieve the discomfort in the legs caused by decreased blood flow, and in some patients, works a bit. So sometimes we do try that. Just as in patients that we've opened arteries in the heart, it's important for that patient to take aspirin and the antiplatelet agents like Plavix. Anybody on taking Plavix in the room? Okay. So we use Plavix in the heart when we open an artery. Actually, no matter what artery we use, no matter what artery we open, that patient is going to be placed on aspirin in addition to Plavix if they're not allergic to them. The reason is that those two drugs in combination decrease the possibility that the the artery that we just opened restenoses or reoccludes. That's not to say it's never going to happen, but the possibility certainly is decreased if those medicines are taken. There are other drugs in the Plavix category that we can also use, but the main one in that category is the Plavix. So when a patient has an artery opened, they absolutely will be taking 3 drugs: aspirin, Plavix, and one of those drugs that I mentioned for the cholesterol. We used to think that, in the early days, we thought that once on Plavix, Plavix for the rest of your life. Okay? And we did that for quite a while. And it's important for doctors to really take a good look at medical information, so it's not just, well, I want to keep you on Plavix for the rest of your life. If I don't have the medical documentation to substantiate that, then I shouldn't just say I'm just going to keep you on Plavix for the rest of your life. So, for the heart, a year after opening an artery, we might get away with 6 months, but we're most often trying to keep the patients on Plavix for a year after opening an artery in the heart. After that, there is not a medical reason to keep the patient on Plavix. The individual patient, once in a while, I'll have a detailed discussion with the patient, and the patient and I will decide whether or not to continue the Plavix or not. However, in general, 1 year after the coronary artery is opened, it's appropriate to come off the Plavix. There's one study that says for the legs, we still get benefit after 3 years, but it's very tough to do 3 years for a patient. And for the most part, we're trying to do a year. Those arteries going to the brain, 3 months. Arteries going to the intestines or the kidneys, 3 to 6 months. Sometimes we'll go out to a year. So in the overall scheme of things, medical information says 1 year. Okay? Aspirin for the rest of your life, cholesterol-lowering drug for the rest of your life. Okay? So, in order to open those arteries in the legs, we have balloons, we have stents, we have a device that cuts the plaque out, we have a device that sands the plaque off, we have a laser that can vaporize the plaque. This is actually a balloon. Once we were actually freezing the plaque. So liquid nitrogen in a balloon, left inflated for a while, we thought we could decrease the possibility that the blockage comes back. So we did that for a while. We don't do that much anymore. Right this minute, the next thing, maybe, anyone have stents in the heart with a drug that was on the stent, a drug-eluting stent? Okay, so, you know, the very beginning, heart-wise, there was balloon, and only the balloon. The balloon would open the blockage, but crack the artery. And many times it was that cracking that made the blockage come back. Then come stents as a scaffolding, seal up the crack, decrease the possibility that the blockage comes back. And then drug on the stent, decrease the possibility that the blockage comes back. What we're working on now is drug on balloon for the legs. So open the blockage with one of those plaque removing devices, inflate a balloon that has drug on it, drug that's going to inhibit the plaque from returning, take the balloon out. Whether or not that's going to stand the test of time, we'll see. We'll see. That's what plaque looks like when it comes out of the body. All right, now, just a little bit about some of the other arteries. The arteries going to your kidneys. there are some patients who have high blood pressure that is very difficult to treat. Okay? Very difficult to treat. Patient's already taking 3, 4, 5 medicines, and the blood pressure still is not controlled. Or the blood pressure's been controlled. Now, all of a sudden, it's out of whack. You're taking the same medicines. Your weight hasn't changed. You haven't decided to increase the salt level of your diet. And I'm saying those things because increasing weight makes your blood pressure go up. Increasing salt in your diet makes your blood pressure go up. But let's just say none of those things are present. And all of a sudden now your blood pressure is a lot higher than it was before. There are things that we can fix that might be the cause. And one of those things is severe blockages in these arteries going to your kidneys. Okay? The sonogram tells me that they're there. Put the catheter in, film the artery, and this is one of those simple balloon it, stent it, and get out of there. And what we find, if that's the case, is that blood pressure goes down. I don't want to say that the blood pressure goes to normal and therefore you don't need any medicines, but certainly your blood pressure would be much easier to control once we open the blockages. Most often the blockages need to be both kidney arteries, sometimes only one. We just went through a major multi-million-dollar study looking to see if the patient whose blood pressure is uncontrolled, no blockage, there are nerves that actually are around the kidney artery, and we can put a device into that artery and kill those nerves. Okay? Multiple companies looking at this. Everyone thinking, boy, we're going to have something fantastic to offer our patients now. Something more fantastic. One study says fantastic results. But then when we do these randomized multi-center controlled trials, now, Dr. Neasman can take a group of patients, of my patients, and look at them and come to a conclusion. But if thousands of patients are looked at in multiple institutions and looked at the same way, and I'm going to say blinded, so we're going to look at them and we're not going to know which procedure we did to see if the procedure that we actually think is going to work, if it's really going to work. That's a randomized, blinded, controlled trial. So when that was done, this killing of the nerves didn't change. The companies immediately stopped. Okay? So we're looking for things to help our patients. Not everything we look at pans out to be the right thing. So the reason to open the kidney artery, predominantly blockages in both arteries, sometimes one of them that is responsible for the blood pressure not being controlled. Okay? This big artery is one of the large ones that feed the intestines with blood. Now, there are many patients with blockages in these arteries to the intestines, but remember, we only want to treat the blockage if there's symptoms. Okay? So, here are the symptoms. Discomfort in the abdomen when the person eats. Could that be an ulcer? Maybe. Discomfort in the abdomen when a person eats to the point that the person starts to eat less. To the point that weight starts to drop. Okay? Most of these patients are women, most often 70s and older. A few are men. The symptoms can be so gradual, though, that the patient really forgets why they're not eating. But weight keeps going down. Pant sizes or dress sizes keep going down. Person's not eating. Well, by the time they get to me, it's time for me to put my hands on, listen to the abdomen. I'm listening for sounds that the blockages make when there's that the arteries make when there's a severe blockage there. We do that same Doppler study that I've been talking about earlier to find the blockage. Catheter gets put in, balloon opens the vessel, a stent's placed. And all of a sudden, weight starts to go up, appetite goes up, and the patient does quite well. So when there's discomfort in the abdomen with eating, to the point that eating less, to the point of weight loss, okay, that's an indication to look for a blockage. Okay? Now, some of the other talks will be strokes, and we'll spend a lot of time just talking about stroke symptoms. But whenever there's a possibility that there are symptoms that are decreased blood flow to a limb, arm or leg, kidneys, the intestines, mention it to your doc so that we can make sure that you don't have something that we can help you out with. Now, the information that I'm sharing with you is for you, but it's also with your friends and family. Because it may not be you that has the problem, it may be a friend or family, and you can basically tell them the information that you heard tonight. Thanks very much. Okay.